drug therapy in the hypertension. Let us start with the first session, the management of hypertension. As per the American Heart Association 2017 guidelines, the hypertension is categorized if it is between 130 to 139 millimeter of Hg systolic blood pressure and 80 to 89 milligram of Hg diastolic blood pressure, considered as stage 1 hypertension. In stage 2, if the systolic blood pressure is more than 140 and the diastolic blood pressure is more than 90, as per the American Heart Association, it is considered as stage 2 hypertension. The drugs which are used in the management of hypertension, these are categorized into two broad categories: the first line and the second line. The first line agents are preferred drug, preferred category, commonly used, and these are A, C, D. These are A, C, D. A means angiotensin converting enzyme inhibitors, or angiotensin receptor blockers. C indicates the calcium channel blocker, and D indicates the diuretics, generally thiazide diuretics. These are the first line agents and generally preferred in the management of the hypertension. Second line agents, secondary agents, the other diuretics including loop diuretic, potassium sparing, and aldosterone antagonist. Direct renin inhibitors, example aliskiren, beta blockers, alpha blockers, mixed alpha and beta blockers, centrally acting alpha 2 agonist, adrenergic neuron blocker, dopamine receptor antagonist including phenyldopa, and the last one is direct vasodilators. So these are the drugs which are used in the management of hypertension. But the first line, remember, A, C, D. Let us see one by one about the angiotensin. Now, angiotensin receptor blocker, you should know the first, what is the system? Renin angiotensin system and its inhibitions. What happens generally? This diagram indicates the renin angiotensin system. The renin is a kidney enzyme. Renin is a kidney enzyme which is responsible for the conversion of angiotensin 1 to the angiotensin 1. And renin is most important here. Without renin, the angiotensin 1 is not able to convert into the angiotensin 1. Angiotensin 1 is converted into angiotensin 2 with the help of the enzyme angiotensin converting enzyme, which converts the angiotensin 1 to angiotensin 2 and this angiotensin 2 is responsible for the vasoconstrictor effect. Generally, angiotensin 2 receptor is categorized into AT1 and AT2, that is angiotensin 1 and angiotensin 2. But remember, angiotensin 2 is responsible for the potent vasoconstrictor activity. Is responsible for the potent vasoconstrictor activity, because this angiotensin 2 receptors is act on the angiotensin 2 receptor. And this angiotensin 2 is act on the angiotensin 2 receptor, and which is responsible for the potent vasoconstrictor activity. Now, if there is a vasoconstriction, we know that the blood pressure is equal to peripheral resistance multiplied by cardiac output. So when blood pressure is equal to peripheral resistance multiplied by cardiac output. If the peripheral resistance is increased, if the peripheral resistance is increased, it means it causes the vasoconstriction. Due to vasoconstrictions, the peripheral resistance is increased. And if the cardiac output is increased, we will see which are the drugs and mechanisms responsible to increase the cardiac output. If the cardiac output is increased and plus peripheral resistance is increased, it results in the increase in the blood pressure. So here the red color are the inhibitors for this renin angiotensin system. The first step is renin. Kidney enzyme is inhibited by a direct renin inhibitor, DRI, and the name of drug is aliskiren. This aliskiren is responsible to inhibit the renin. If there is a no renin, if there is a no renin, there is a no conversion of angiotensinogen to angiotensin 1, and there is a no angiotensin 2, and we can say there is a no vasoconstriction. If there is a no vasoconstriction, no peripheral resistance, no increase in blood pressure. So we can say renin, which is a kidney enzyme which inhibited by the direct renin inhibitor, and example of drug is aliskiren. Second step here, angiotensin 1 is converted into angiotensin 2 by the enzyme angiotensin converting enzyme. So we have the category of drug, the first line drug, angiotensin converting enzyme inhibitors, and the name of drug is captopril, lisinopril, isinopril. All the suffix with the pril considered as angiotensin converting enzyme inhibitors. If there is a no enzyme, there is no enzyme of which enzyme? Angiotensin converting enzyme. There is a no conversion of angiotensin 1 to angiotensin 2. And if there is a no angiotensin 2, there is a no vasoconstrictor, no peripheral resistance, and there is no increase in blood pressure. We can say it causes the vasodilation and it will relax, or we can say it will not cause the increase in the blood pressure. So if we see the equation for the blood pressure is equal to peripheral resistance multiplied by cardiac output. So we have to take care of two steps here. We have to maintain or decrease the peripheral resistance, and we have to also decrease the cardiac output. Decrease means we have to make it at normal level, not decrease. The cardiac output and the peripheral resistance should be the normal to maintain the blood pressure. But here, if you are using angiotensin converting enzyme inhibitor, what about the cathepsin and chymase? If the person having the cathepsin and chymase, these two enzymes also responsible for conversion of angiotensin 1 to angiotensin 2 and may causes the vasoconstriction, increase in blood pressure. So if there is a failure of therapy, you are giving angiotensin converting enzyme inhibitor to the patient and still there is a blood pressure, vasoconstriction. So it may be due to cathepsin and chymase. Let us see the actions of angiotensin. Generally, the angiotensin 1 has no pharmacological actions, but angiotensin 2, it act on two receptor, AT1 and AT2, that is angiotensin 1 sub receptors. So what is the action of this sub-receptor of angiotensin 1? It produces vasoconstriction, and due to vasoconstriction, it increases the systolic and diastolic blood pressure, and this vasoconstrictor activity of angiotensin 2, it is in the 8 times more potent than noradrenaline. It is 8 times more potent than noradrenaline. So the main, if this angiotensin 2 is responsible for the blood pressure, it is due to the vasoconstrictor activity due to peripheral resistance. Second activity, what is the second action of this angiotensin? It increase the aldosterone secretion and increase antidiuretic hormone secretion. What is the result? If the aldosterone secretion increase, it also causes the vasoconstriction. It increase the sodium and water reabsorption from the kidney. Sodium and water is reabsorbed, so blood volume will be increased. If the antidiuretic hormone is increased, same vasoconstriction, water reabsorptions from the kidney. It also increases the synthesis and release of catecholamines, which is having vasoconstrictor activity. Also increase the central sympathetic outflow, increase the hypertrophy and proliferation of vascular smooth muscle. So this hypertrophy and proliferation is important for the myocardial infarction patients. Increase the hypertrophy of cardiac muscle fibers. It also having positive ionotropic and chronotropic effect. Positive ionotropic and chronotropic effect means it is having the forceful contractor activity at its central and peripheral sympathetic stimulation, and also weak direct positive ionotropic effect. Positive ionotropic effect indicates the positively charged ion, including sodium, goes inside to the myocardial cell muscle, and these are responsible for the contract contractions activity, including calcium channel, calcium ions, forceful contraction, and these are responsible for the forceful contractions of the heart muscles. They are responsible for the angiotensin 2. We are talking about the angiotensin 2. We are not talking about the angiotensin converting enzyme inhibitors. This angiotensin 2 is also responsible for the vasoconstrictions of renal afferent arterioles. And if there is a constriction activity at the renal efferent arterioles, it also causes the peripheral resistance. And last one, it may causes decrease in the renin release. So these are the many actions of angiotensin 2. And if we see what is the conclusion of this all the action, we should know the angiotensin 2 is responsible for the vasoconstrictor effect. It is a potent vasoconstrictor. It is it causes the increase in the peripheral resistance, and due to increase in the peripheral resistance, it also causes the increase in the preload, and it increase in the preload, it causes the increase in the blood pressure. So here this figure indicates the afferent arterioles and the efferent arterioles in the glomerular capillaries. In afferent arterioles, the blood inlets into the glomerular capillaries. It may causes vasodilation, which is mediated by the prostaglandins. Vasodilation decrease the peripheral resistance, good for the maintain the high blood pressure. But non-steroidal anti-inflammatory drugs reduce the prostaglandin synthesis. And if there is prostaglandins are not available, it it does not causes the vasodilation, and therefore the non-steroidal anti-inflammatory drugs are generally contraindicated in the persons with the problem of the kidney diseases. This angiotensin 2 is responsible for the vasoconstrictions, which is mediated by the angiotensin 2 vasoconstriction. If we give angiotensin converting enzyme inhibitors, it reduces the production of angiotensin 2 and reduce the vasoconstriction. If the vasoconstriction is relieved, means the peripheral resistance is relieved and the blood pressure will be maintained. On subreceptor of angiotensin 2 AT2 receptor, it produces vasodilation due to local increase in the bradykinin. And these are the mixed action of the AT2 receptors, including anti-proliferation and apoptosis. And there is also angiotensin third receptor, which is also having the vasoconstrictor activity and increase in the aldosterone secretion, but less than angiotensin 2. So here, what is the conclusion? The renin angiotensin system is very important to maintain the blood pressure. So how, which are the drugs which affects the renin angiotensin system? We can give the renin, the kidney enzyme is responsible for, as we seen in the figure, this renin enzyme is responsible for the conversion of angiotensinogen to angiotensin 1. So we can inhibit the renin by using the beta blocker and centrally acting drug like the clonidine, alpha methyl dopa. We can also directly renin inhibitors. We have aliskiren. We can also inhibit the conversion of angiotensin 1 to angiotensin 2. Like this mechanism, conversion of 1 to 2, by the use of angiotensin converting enzyme inhibitors, captopril, lisinopril, eosinopril, the pril derivatives. And third one, we can affect the renin angiotensin system by angiotensin second receptor blocker. Examples: losartan, valsartan. So if Here, if the patient is not get benefit from the angiotensin converting enzyme inhibitors, because cathepsin and chymase may convert angiotensin 1 to angiotensin 2. So in this case, we need to the drugs or the medications which oppose the action of angiotensin 2. So the best way, use angiotensin 2 receptor blocker. Even if the cathepsin and chymase will convert angiotensin 1 to 2, our angiotensin 2 receptor blocker will not create vasoconstriction, will not create peripheral resistance, and thereby the blood pressure will be maintained. So angiotensin 2 receptor blockers are here losartan, valsartan, and generally suffix for the angiotensin 2 receptor blockers are tan. We can say sartan, losartan, valsartan. So these are the specific renin angiotensin systems, and most commonly used generally we are using the ACEI inhibitors, that is angiotensin converting enzyme inhibitors, and the best one is angiotensin 2 receptor blocker. What is the limitations of this angiotensin converting enzyme inhibitors? If we inhibits this enzyme, angiotensin converting enzymes, but this drug will not inhibit the this our angiotensin converting enzyme inhibitors will not inhibit the cathepsin and chymase. So if the cathepsin and chymase is not inhibited, so angiotensin 1 will be converted to angiotensin 2, and it causes increase in the blood pressure by the vasoconstrictions. So best way to use angiotensin 2 receptor blocker, even if the cathepsin chymase or ACE converts 1 to 2, no problem, we will block the receptor. If the angiotensin 2 receptor is blocked, there is no vasoconstriction, no vasoconstriction, no peripheral resistance, and the blood pressure will be managed. The classification of angiotensin converting enzyme inhibitors. Now these ACEI inhibitors are classified according to their chemical nature. Angiotensin converting enzyme inhibitors with sulfa hydryl group, sulfa hydryl SH, sulfa S hydryl H, sulfa hydryl group. Examples are the captopril, elacepril, and zofinopril. Angiotensin converting enzyme inhibitors with dicarboxyl group, enalapril, ramipril, and benzapril. All suffix are pril. And angiotensin converting enzyme inhibitors with phosphonate group, fosinopril. Now sulfahydryl group, this table may be used for your MCQ, but remember sulfahydryl group having some disadvantage. Let us see mechanism of action. Obviously they inhibit the angiotensin converting enzymes, decrease the angiotensin 2 formation, and if there is a no angiotensin 2 formations, it's decrease its action on AT1 receptor, and it causes the vasodilation mixed vasodilation, and also it prevents the inactivation of the bradykinin. So here our aim of therapy is we have to prevent the vasoconstrictions caused by the angiotensin 2 formation. Here our main aim of the treatment to stop the vasoconstrictions, and thereby We need to stop the angiotensin 2 formation. Now, what is the pharmacological effect of angiotensin converting enzyme inhibitors? Now, still we discuss about the what is the effect of angiotensin 2. Now we will discuss the drug medications which inhibits the angiotensin converting enzyme inhibitors like the pril derivative. What is their action? First one is these are vasodilator mixed, and as a principle of blood pressure management, the most important is blood pressure is equal to peripheral resistance and cardiac output here. Please remember. Now, if there is a peripheral resistance means vasoconstriction. Vasoconstrictions responsible for the peripheral resistance. Just a minute. Okay. So these ACEI inhibitors decrease the peripheral resistance by inhibiting the vasoconstrictions. So that's why it is called mixed vasodilators. The first one is it causes the arteriodilator. If there is a dilation in the arteries, decrease in the peripheral resistance. And if the peripheral resistance is decreased, there is decrease in the blood pressure. So this mechanism we need: decrease the peripheral resistance, decrease the blood pressure. This decrease in the blood pressure may result in decrease in upper load, and if the upper load is decreased, it will increase the cardiac output in patient with the heart failure. And um, in heart failure we have to increase the cardiac output. So this medication also used in the management of congestive heart failure. If there is a vasodilator, it decreases the venous resistance and decrease in the preload. If the preload is decreased, it may causes the increase in the cardiac output, and it will also benefit in the patient with the heart failure. In addition to this, so in conclusion, we can say that it causes the mixed vasodilation and it decreases the peripheral resistance and decrease the afterload and preload. So this angiotensin converting enzyme inhibitor decrease the afterload and decrease the preload, and most suitable for the patient with the congestive heart failure, because in the patient of the congestive heart failure we have to increase the cardiac output. Decrease the proliferation and hypertrophy of vascular muscles due to decrease in the peripheral resistance. No peripheral resistance, there is a no hypertrophy. So it is also useful in the patient of the myocardial infarction. Decrease in the hypertrophy of the cardiac muscles. And there is one questions: if it does not count increase in the heart rate in spite of decreased blood pressure, it decreased the blood pressure but the heart rate is not increased. Why? Because what happened, due to some reflex tachycardia, there is increase in the heart rate, but the angiotensin converting enzyme inhibitors does not cause increase in heart rate. Because these drugs, angiotensin converting enzyme inhibitors, it causes more parasympathetic activity. And if the parasympathetic activity is increased, the heart rate will not increase. If these angiotensin converting enzyme inhibitors also reset the baroreceptor reflex sensitivity to downward. So no increase in the heart rate. And it also causes the venodilation. Due to venodilation, it inhibits the brain bridge reflex, and which is responsible for decrease in heart rate. So it is also having the vasodilatory effect of both afferent and efferent arterioles of kidney. Why? Because angiotensin 2 is responsible for vasoconstriction. And if we inhibit the angiotensin 2, it causes the vasodilation. And the most important in the congestive heart failure, it increase the cardiac output and decrease the heart rate, just we discussed here. And they may maintain the cerebral and coronary blood flow even when the systemic blood pressure is low. So these are the all benefits of the first line agent angiotensin converting enzyme inhibitors. This is the preload and afterload. This image is clear about the preload and the afterload. Preload before and afterload means after the heart. Preload volume of blood in the ventricles at the end of diastole in diastolic pressure, and it is increased if there is a hypervolemia, increase in the blood volume, regurgitation of the cardiac wall, and the heart failure. While afterload, resistance left ventricles must overcome to circulate blood, and it is increased in the hypertension and vasoconstrictions. What is the use of angiotensin converting enzyme inhibitors? It is used in the management of hypertension, congestive heart failure, myocardial infarction. Because in the myocardial infarction, the remodeling, the post-infarction ventricle remodeling, it is used. It is also used with the chronic kidney disease, but should not be used if the patient is having renal artery stenosis, contraindicated. And it is recommended all patients with diabetic and microalbuminuria, even if the blood pressure is normal, use angiotensin converting enzyme inhibitors if the blood pressure is normal and the patient with diabetics and microalbuminuria. Why? Because this angiotensin converting enzyme inhibitors increases the sensitivity of insulin receptors. So if the sensitivity to the insulin is increased, the utilization of the blood glucose level will be increased, and therefore it will decrease the incidence of diabetic microalbuminuria, the albumin in the urine. So generally the use of angiotensin converting enzyme inhibitors is recommended in the diabetic and the patient with microalbuminuria. Now we have the less than a minute. Please join again. If we disconnect, please join again. Side effects of angiotensin converting enzyme inhibitors, they are considered as captopril, the name of drug. Side effect of angiotensin converting enzyme inhibitors, captopril. See, captopril, CAPTOPRIL. These are the side effects. Cough and bronchospasm. Why? is the most common side effect and intolerance of angiotensin converting enzyme inhibitors, cough and bronchospasm. Because the bradykinin increase in the bradykinin is responsible for the cough. Bradykinin is a mediator of the histamine. It is one of the mediator for the histamine and which is responsible for the cough. Is the most common effect or intolerance. We can say bradykinin and the prostaglandins. It causes the increase in the prostaglandins, and due to this there is a cough. So if it is cough, it is relatively contraindicated in the COPD. The person having